Hello everyone, it's Miss Merle once again. Guys, imagine a patient needing a blood transfusion, but their body possesses hidden antibodies that could attack the new blood. How do we find them? So the answer lies in anti-human globulin testing. So today I'll explain the science behind this vital reagent and its role in detecting both in vivo and in vitro sensitization of red cells. So we will explore the anti-human globulin test. So it's commonly known as the Coombs test, which plays a vital role in medical diagnostics, especially in immunohematology. So to begin, it is essential to distinguish between two primary types of these tests. So we have your DAT, the direct anti-human globulin test, and the indirect anti-human globulin test, or IAT. So the direct test identifies antibodies that are already attached to the surfaces of red cells, so making it particularly valuable for diagnosing conditions such as autoimmune hemolytic anemia. Conversely, the indirect test detects free floating antibodies in the bloodstream that may interact with red cells. So, this test is crucial for prenatal screening and ensuring compatibility for blood transfusion. So, grasping the significance of these tests is instrumental in effectively identifying and managing the range of blood related disorders. Can anyone provide an example of a situation in which these tests might be critically important? So, here, guys, that's one of the things that you can really put into your minds and remember because that's the significance of having HG. We will dig deeper into the principles and procedures of these tests shortly. So, please hold on to any questions you may have, and until then. So, uh, hmm. Welcome, everyone, to our session on anti-human globulin testing. This is also known as your COMS test again. Let's start by outlining the key topics we'll cover. We'll begin with the principle behind the AHG test, which is foundational to understanding its application. Then we'll move on to the procedure, focusing on both DAT and IAT. And understanding this procedure will help you really appreciate their uses and differences. Next, we'll discuss the specimen types needed and the materials required for conducting these tests effectively. So, this will be followed by a detailed look into your quality control to ensure accuracy in your results. And finally, we'll cover the reporting of results, which is a very crucial step in communicating findings accurately and effectively. So, throughout this presentation, remember that our goal is not only to understand the technical aspects, but also to appreciate the importance of these tests in ensuring patient safety. So, for the laboratory objectives, first you'll learn about the principles and applications of both direct and indirect anti-human globulin testing. Understanding these principles is foundational to your work in the lab. Next, you'll compare and contrast DAT from that of IAT. So, this comparison will help you clarify when to use each type of test. Then, you'll also explore the various reagents used in HG testing and how they differ from one another. So this knowledge is crucial for the accuracy of test results. And finally, we'll cover the zeta potential theory, which is an important concept to grasp the interactions within AHG testing. So mastering these objectives will greatly enhance your proficiency in laboratory diagnostics. So the AHG test is a procedure that plays a vital role in transfusion medicine. So it's developed by Robin Coombs. We have Arthur Morant and Robert Race in the year 1945. And the test is based on the principles first described by Morisky in 1908. And this test essentially relies on the ability of the anti-human globulins from immunized non-human species to bind with human globulins such as IgG or complement. So, one of the most critical applications of the AHG test is its ability to detect globulins. So, these can either be free floating in the serum or attached to red blood cell antigen. So, this detection is crucial because it helps us identify potential issues that could compromise patient safety during blood transfusion. So, understanding how the AHG test works not only enhances our knowledge of immune hematology but also underscores the importance of safety in medical procedures. So, types of blood group antibodies. We should let's break down their characteristics and roles. So, firstly, IgM antibodies have a pentameric structure, And this unique structure allows them to directly agglutinate red blood cells when placed in saline. While on the other hand, IgG antibodies are smaller, typically existing as monomers or dimers. And because of their size, they are unable to directly agglutinate red blood cells. This characteristic is why they are often referred to as non agglutinating or incomplete antibodies. Then, this differentiation plays a significant role in how we approach testing and interpreting results in transfusion medicine. So, here, understanding zeta potential, again, zeta potential is essential in grasping or understanding how red blood cells interact with one another. So, to put it simply, zeta potential, it refers to the electrostatic charge that surrounds the red cells, and this charge is primarily negative, and it's what keeps these cells from clumping together spontaneously. So the negative charge originates from the RBC membrane itself, creating a sort of protective barrier that ensures the cells remain separate. And this concept is vital. Why? Because it explains why, under normal conditions, our blood cells circulate smoothly without forming unwanted clumps. So, in summary, zeta potential is a key player in maintaining the fluidity and proper function of our blood. And as we move forward, we'll explore how this principle is applied in different types of HG tests, which are essential in transfusion medicine. Because, guys, remember, this large structure, this pentameric structure of your IgM can easily bridge the distance between two red cells. Your IgG cannot. It's very small. It's only 14 nanometers as compared to your 35 nanometer IgM. That's why we need to, it could be that the RBCs are coated with the IgG and then we might not detect it. So we need to have your anti-human globulin, which will attach to the IgG so that they can be detected. So, when discussing the two types of AHG tests, it's essential to make clear distinctions to avoid confusion. So, let's break it down. We have the first type is your direct Coombs test, DCT or DAT. Then, this test is crucial in identifying antibodies that are already attached to red cells. It's commonly used when there is a suspicion of immune mediated hemolysis. So, this is when the body's immune system mistakenly attacks its own red blood cells. The second type is the indirect Coombs test or ICT or IAT. So unlike DAT, this test detects free antibodies present in the serum that have the potential to bind to red blood cells. So the ICT is or IAT is a cornerstone in blood bank procedures, regularly employed for screening and compatibility testing. So this includes antibody detection, antibody screening detection, we have identification, and even antibody titration. So it's important to highlight how these tests fit into the broader clinical settings. So, in summary, your direct Coombs test is reactive, addressing issues as they arise, while the indirect test is proactive, so safeguarding against future complications. So, this understanding is vital in both clinical diagnosis and prevention. So the AHG test is it's pivotal for detecting human globulin molecules, whether they're bound to red cells or free floating in serum. So it employs reagents from rabbits that specifically react with human antibodies. So the two main types of AHG tests, we have the DAT, which identifies antibody binding on red cell surfaces that occurs in the body. Meanwhile, the indirect antiglobulin test or IAT detects antibodies in a test tube setting, so allowing us to see how RBCs react to to blood group antibodies. And then understanding these principles helps us ensure safe blood transfusions, guys, and diagnose conditions like hemolytic anemia efficiently. So it's really essential for us to understand how our HG testing works and how what are its applications in the clinical setting. So let's begin. So the HG test involves adding HG, which contains anti-IgG. So your anti-human globulin reagent contains anti-IgG anti-IgG to red blood cells that has been synthesized with IgG antibodies. So this process can lead to heme agglutination, which is a visible clumping of cells that indicates the presence of antibodies. Now, why is this significant? Because the AHG acts as an antibody, helping us to reveal antigen antibody complexes that might otherwise go undetected. So, this insight is vital for diagnosing and managing conditions related to blood group incompatibility. So, additionally, some group antibodies have the ability to bind complement to red cells. In these cases, a polyspecific AHG reagent can be used, which includes an anti-complement component. So this ensures we capture all possible interactions, providing a comprehensive view of the immune response. So by understanding these interactions, we can more accurately interpret these test results, leading to a better patient outcomes. So let's move forward to the next slide to explore potential challenges and errors that might happen or occur during these tests. So false negative results may be due to the following. So one, inadequate or improper washing of red blood cells can prevent the removal of any unbound antibodies, leading to inaccurate results. So make sure the washing steps are performed thoroughly and consistently. Another factor is the deterioration of reagents or their neutralization. Always check the expiration dates and storage conditions of your reagents to ensure they are in optimal condition. Additionally, the AHG reagent might not be added, you forgot, or the serum might be omitted in the indirect test, both of which are critical components for accurate detection. So you should be very vigilant and always have a presence of mind when doing the test. So do not omit or forget any reagent. In some cases, the serum might not be reactive because of complement inactivation. So this could happen if the serum has been improperly stored or handled. So ensure that incubation conditions are adequate in the indirect test, as inadequate conditions can affect the binding of antibodies to antigens. So pay attention to the cell suspension concentration. If it's either too heavy or too weak, it can skew the results. Aim for the correct density for accurate readings. Lastly, under centrifugation, guys, and poor reading techniques can also really contribute to false negative results. So ensure that centrifugation is done at the correct speed and duration, and develop a keen eye for interpreting results accurately. So remember, understanding these causes can significantly improve the reliability of your HG test results and help you avoid potential pitfalls. So for the false positive results, they can arise or may arise in the following circumstances. So let's take a look. First, these can happen when the specimen use is improper, such as being refrigerated or clotted, which may lead to in vitro complement attachment. Additionally, auto-agglutinable cells can contribute to false positives, so this means the cells may naturally clump together, mimicking a positive reaction. Bacterial contamination, whether in the cells or the saline used for washing, is another factor that can interfere with the test results. It's crucial to ensure all materials are clean and sterile. Moreover, if cells possess a positive DAT in an indirect AHG test, it can yield misleading results. Okay? Contaminants in saline, such as heavy metals or colloidal silica or even dirty glassware, can also cause false positive results. Again, dirty glasswares, dirty test tubes, the use of dirty test tubes can also cause, or slides can cause false positive results. So finally, over centrifugation and overreading, as well as polyagglutinable cells or preservative dependent antibodies in list reagents, might lead to inaccurate results. As we move forward, bear in mind, guys, that these factors when interpreting test results to ensure accuracy and reliability. Bear in mind, huh? Then, so let's have how is AHG produced? So, how this vital component is made and why it's essential for our tests. So, to begin with, AHG reagent is made by It's created through a fascinating process. Animals like rabbits are injected with human IgG and complement proteins. This prompts the animal's immune system to produce antibodies against these human proteins. Now the magic happens. When the AHG reagent is formulated, it contains anti-IgG and anti-complement antibodies, specifically anti-C3d and anti-C3b. So these antibodies are capable of binding to human IgG and complements proteins, whether they are freely circulating in the serum or attached to red cells. So this binding capability makes HG reagents invaluable in enhancing our detection of antibodies during various tests. So it ensures that even low levels of antibodies don't go unnoticed, thereby increasing the accuracy and reliability of our results. So here we have let's differentiate a polyclonal antibodies from monoclonal antibodies, guys. So for the definition, so antibodies derive from multiple B cell clones, hence polyclonal. And since polyclonal, they can recognize multiple epitopes on an antigen. How about a monoclonal antibody? Antibodies produced from a single B cell clone, recognizing a single epitope on an antigen. How are they produced? Polyclonal antibodies are obtained from immunized animals like goats or rabbits. So we have leporine or caprine. And then in origin, or we can have murine from the mice from mice. How about monoclonal, produced using hybridoma technology? How about specificity? So it binds to multiple because it's polyclonal epitopes and antigen. This one binds only, it's highly specific, and will only bind to a single epitope or antigenic determinant. How about reproducibility? So this one is polyclonal, it's less consistent due to variability reasons. And then how about monoclonal antibodies? Highly consistent and reproducible. How about your sensitivity? This one is more sensitive in detecting antigen variations, while for monoclonal antibodies, they're highly consistent and reproducible. No, no. So more specific and it reduces false positives. So if you wanted something of high specificity, binds to a single epitope, it's highly reproducible and consistent, choose your monoclonal antibodies. But guys, it still depends on its application because polyclonal antibodies are used in AHG testing. But yeah, they can be used, but the one which is preferred for AHG testing is the monoclonal antibody. Okay? This one can be used for immunoassays and research, but this one for therapeutic use, so more it's more on pharmacology, and then research requiring high specificity. So this one definition again, each reagent containing antibodies against both IgG. So by definition, define a polyspecific AHG reagent. It's an AHG reagent with antibodies against both your IgG and your C3b, and but this one either it could be for your non-specific AHG, that this reagent contains only antibodies against either your IgG or that of your complement C3b or C3d, not both. If you wanted something both, then that's your polyspecific. So see, hence the component. This one has both anti-IgG and anti-C3. C3b or C3d. But this one, either it could only have it's an anti-IgG or anti-C3. Okay? What's the usage? For the initial screening in DAT and IAT. So that's for your specific HG. But if you wanted to differentiate whether sensitization is due to IgG or complement, that's your non-specific HG. This one, for the advantages, we have broader detection of antibody-coated RBCs and complement-coated RBCs. So if you wanted to have something in general to detect a lot of what are those antibodies coating those RBCs, so then we can utilize the specific AHG. But for the monospecific AHG, this one is more specific man, helps identify the cause of RBC sensitization. So we have disadvantages, may give non-specific results, and it needs you to do further testing. But this one, they can all, nothing is perfect. So still, it has a disadvantage. So may miss certain cases where both IgG and complements are involved. So, preparation of polyclonal AHG reagents. So, when preparing the polyclonal AHG reagents, it's vital to understand the balance between the breadth of reactivity and the limitations of the antibody source. So, polyclonal reagents are derived from the pooled donor antigen, which this one contributes to the wide range of reactivity because it's pooled man, diba? However, a key limitation is that the source of the antibodies is restricted to the lifespan of the inoculated animal. So this means the production is inherently finite and must be carefully managed. So, when we talk about polyspecific anti-human globulin, it refers to a combination of polyclonal anti-IgG with either polyclonal or monoclonal anti-complement components. So, this combination allows for a versatile, comprehensive reactivity, which is crucial for effective application in various diagnostic and therapeutic contexts. So, understanding these intricacies will set the stage for our next discussion on monoclonal AHG reagents, where we will explore how hybridoma technology overcomes some of these limitations. So here, the hybridoma technology, preparation of your monoclonal HG reagent. So when discussing the preparation of our monoclonal HG reagent, so it's really important to highlight their durability and specificity. So these antibodies produced from hybridoma technology for monoclonal anti-human globulin. So have the advantage of being produced by hybridomas, which can live indefinitely, so immortal. So this longevity means that the production of antibodies is more reliable. It's more reliable and sustainable compared to the polyclonal sources, which rely only on the lifespan of the donor animal. So a critical aspect of manufacturing monoclonal HG reagents is the blend of specific components. So a monoclonal blend is created by combining monoclonal anti-C3b, monoclonal anti-C3d, and monoclonal anti-IgG. It's a blend. So this precise combination ensures that the reagents are highly specific to the antigens they are designed to detect. And additionally, these reagents can be produced either conventional methods or the advanced hybridoma technology, which offers consistency and precision in antibody production. So this approach provides us a more standardized and reliable tool for laboratory diagnostics. So this one, tasks and purposes of the indirect antiglobulin test, IAT. So if the task you're incubating your RBCs with the antisera, this will it allows time for the antibody molecule attachment to RBC antigen. So there's this, it allows binding. How about if you're performing even just at least three saline washes? So what's the purpose? We can remove the free globulin molecules. How about if the next task is about adding antiglobulin reagents so that we can form RBC agglutinates. So your RBC antigen plus your antibody plus your anti-IgG. How about centrifugation? What's the purpose why we need to centrifugate? It accelerates agglutination by bringing cells closer together. So that's for centrifugation. And examine for agglutination so we can interpret the test it's positive or negative, and then grade agglutination reaction. So determines the strength of the reaction. So it's like negative, 1 plus 2 plus 3 plus 4 plus, and add antibody coated RBCs to negative reaction. So checks for neutralization of anti-sera by free globulin molecules. So that's your Combs control cells, the check cells, which are D positive RBCs with anti-D. So group O, Rh positive. Those are your check cells. So for the procedure, this will be flashed into the your through a projector in your classrooms, lab room, sorry, during on Monday, and you will be following this. So we will be doing for the manual method, you have direct HG and direct HG. Why two? Because you will be having your patient one as your classmate, another classmate for patient two and patient three, and this one is an unknown. So you'll be extracting one EDTA. So the sample here is EDTA for your direct, and in your indirect, you'll be having EDTA, and then you'll be having serum. So here, prepare a 5% RBC suspension from wash red cells of patient one. So wash only 1 ml of whole blood or half of your EDTA. And then in a test tube labeled patient 1, place 2 drops of RBC suspension, followed by the addition of 2 drops of your AHG reagent. And then, uh, well, the color of your HG reagent is green. So it's a combination of patent blue and tartrazine yellow. Or you can just answer tartrazine and then patent blue. So those are the dyes responsible for the green color of your HG reagent. I just wanted to mention it. Sorry for injecting it in the procedure. And then certification at 3,200 RPMs, revolutions per minute for 15 seconds, guys, only. Then read and grade the reaction. So in a test tube labeled unknown, so this is your unknown. So this is the exciting part. So you'll be doing the similar um, procedure, but this is really an unknown. And then how about your indirect AHG? You will extract one EDTA tube from patient 2, extract one red top tube from patient 3. Then out from your EDTA, you need to prepare a 5% RBC suspension from wash red cells of your patient 2. Yeah, that's why. Wash only 1 ml of your whole blood or half EDTA, and then in a test tube labeled IAT and group number, place 2 drops of RBC suspension of patient 2, the RBC suspension. Then add 2 drops of serum of patient 3 into the same test tube. Incubate the tube at 37 degrees centigrade in a water bath for 15 minutes. Remove the tube from the water bath, centrifuge, and resuspend. Observe for agglutination or hemolysis. If there's no agglutination, wash the serum cell mixture 3 times with NSS, but not much. You can just use like 1 ml to 1.5 ml of your NSS in this one. And then after the third washing, add 2 drops of HG reagent, mix and centrifuge at 3,200 RPM for 15 seconds. Then read and grade the reactions. So reporting of results. So when it comes to the reporting of results, agglutination is a key indicator in both the direct and indirect. So in your DET procedure, agglutination signals a positive result, which is due to the in vivo sensitization of antibodies coating the patient's red blood cells. So this means that within the body, these antibodies have already attached themselves to the RBCs. But in contrast, for IAT, agglutination also indicates a positive result, suggesting in vitro sensitization. So these tell us that there's an antibody that could potentially react with the patient's RBCs when the test is performed outside the body. Again, this will tell us, it will dictate us that there is an antibody that could potentially react with the patient's RBCs when the test is performed outside the body. So, these results are crucial as they help us understand how antibodies interact with RBCs in different environments, guiding us in the appropriate clinical decisions. So, here, importance of red cell washing. So why this step is essential? So first, red cell washing effectively removes any unbound antibodies. So removal of any unbound antibodies or complement proteins. So that should be our answer, how, why you're washing. So before adding the HG reagent. So this step is vital because any residual antibodies can interfere with the test, leading to the inaccuracy of the test results. So the process involves mixing red cells with saline, spinning them in a centrifuge, and then carefully decanting the wash. Be careful in decanting the wash because sometimes you're just like pouring out the wash. So this ensures that all unbound particles are washed away, leaving only the cells of interest. So one critical point to remember is that inadequate washing can cause the H0 agent to be neutralized. So this in turn may produce a false negative result, which is something we want to avoid at all costs in our testing. So, to ensure the washing process is thorough, we add IgG sensitized cells to any negative test tube. So, this step confirms whether the washing was adequate by checking for any signs of neutralization. So, by adhering to this meticulous process, a washing process, guys, we can confidently interpret our test results. So, yeah, that's it. So here, the interpretation of results, focusing on the significance of both negative and positive outcomes. So let's start with the negative test. So a negative test where there's no agglutination that happens or occurs. So This dictates us that neither IgG antibodies nor complement proteins are present on the red cells. This is a crucial finding, Manjud, because it helps us to rule out certain conditions related to red cell sensitization. So, on the other hand, indicated by a positive result is indicated by agglutination. So, suggests that IgG antibodies or complement proteins have indeed attached themselves to the red cells. So, this attachment can be indicative of underlying conditions that warrant, sorry. So purpose of DAT. So this one is a crucial tool for identifying immune-related issues with red cells. So under normal circumstances, the red blood cells do not have IgG or complement proteins attached to them in the body in normal physiological circumstances. However, DAT helps us detect these proteins when they are bound to patient red cells, which can be due to several conditions. So what are those conditions? These conditions include autoimmune hemolytic anemia. We have the hemolytic disease of the newborn, a fetus and newborn, and antibody reactions to transfused red cells, and a positive DAT results results suggest that there might be immune mediated destruction of red cells leading to anemia. So yeah, that's it, guys. Then, how about the purpose of IAT? So, IAT is a key component in our understanding of blood compatibility. So, di ba? So, it's specifically designed to detect antibodies that have attached to red cell antigens outside of the body, in vitro. So, this is a critical process because as it helps us identify antibodies that react with specific red cell antigens, which is essential for safe blood transfusions and organ transplants. So, this test is particularly important as it allows us to identify potential immune responses before they occur inside the body, thereby preventing adverse reactions in patients. So here, indirect antiglobulin test, we have the application because for example, you'll be asked what are the applications of your IAT. Your IAT applications include antibody detection, antibody ID, and your antibody titration, and you also have your RBC phenotype. So, specifically under antibody detection, we have compatibility testing. So, this one, in vitro sensitization, recipient antibody reacting with the donors. Then we have antibody screening, antibody reacting with screening cells. So for antibody identification, we have the test is known as your antibody panel. So antibody reacting with panel cells, and then antibody titration. So the test will be Rh antibody titer. So an antibody and selected Rh cells. So with your RBC phenotype, we have your RBC antigen detection, and we also have your specific anti-sera plus RBCs to detect the antigen. So what's the sample here for your DAT? The preferred sample of choice always is EDTA. Reason? So it prevents in vitro complement activation. So again, it prevents the complement system from activating outside the body, which helps ensure that the results reflect only what occurred in the patient system. While ACD and CPT samples can also be used, guys, it's crucial to avoid using plasma. Using plasma may lead to false results, particularly for antibodies that depend on the complement system. So that's it. So remember, proper sample collection is vital for accurate test results. So always ensure EDTA is used to prevent any misleading outcome. So EDTA for DAT. EDTA, DAT. Significance of a positive dot. So guys, this one confirms antibody or complement attachment due to clinical condition. So that's it. Yeah. So it's important to note that unlike other tests, no incubation is required here because the antibody attachment occurs naturally inside the body or in vivo. So this makes the test more forward and less time consuming. And finally, always interpret the results of a DAT in conjunction with the patient's medical history and current clinical condition. So guys, sources of error in anti-human globulin testing, false positive results. Yeah, that one, improper specimen. So refrigerated or clotted. We had this already earlier. Over centrifugation and overreading. Centrifugation after an incubation phase when polyethylene glycol or other positively charged polymers are used. We have bacterial contamination or saline is used in washing dirty glassware is false positive. Also the presence of fibrin in the test tube, so mimicking agglutination. Cells with a positive DAT will yield a positive IAT, so false positive results. Saline contaminated by heavy metals or colloidal silica. Using a serum sample for DAT, samples collected in gel separator tubes, so an authentic complement attachment when specimens are collected from infusion lines, so dependent antibody drug against reagents, although all those things can cause false positive results. We also have false negative results, false neg. So if you are not properly washing your cells or the wash was inadequate, so it can lead to false negative results. Failure to wash additional times when increased serum volumes are used. Contamination of AHG by extraneous protein. High concentration of IgG paraproteins. Early dissociation of IgG from RBCs due to interruption in testing or due to improper testing of using the temperature. Your saline, or it could be the AHG is too hot or too cold. So, and please go over with these things, guys. And then, so let's have the factors affecting the HD testing itself. So, it's important to highlight their capabilities in detecting molecules on red blood cells, man, diba, with the DAT and AT. So, this one. Learn that that can detect between 100 to 500 IgG molecules to 400 to 1,100 C3D molecules per red blood cell. So this makes it a powerful tool for diagnosing conditions related to antibody-mediated hemolysis. So move on to IAT, which requires fewer molecules for detection. Gamay lang, no? So a minimum of 100 to 200 IgG or C3 molecules per red blood cell is needed for us to arrive on a positive result. So this test is often used in blood compatibility testing before transfusions. So by understanding these sensitivities, medical professionals can better interpret test results and make informed decisions about patient care. So factors affecting the HG testing here, guys, consider the ratio of serum to cell. So the proportion in which these components are combined can significantly impact the test's sensitivity. Next, the reaction medium plays a vital role, so it can facilitate interactions between antibodies and red blood cells affecting the outcome. Temperature is another critical factor, so the right temperature ensures optimal conditions for the test reaction to happen, and then incubation time must be carefully managed to allow adequate interaction between test components. The washing of red cells is necessary to remove any unbound antibodies which could otherwise give false results. Using the correct saline solution for washing is important for maintaining the integrity of the test. And the addition of HG or anti-human globulin reagent is the heart of the test, linking antibodies to the cells. Finally, centrifugation helps in reading the results by promoting the binding of antibodies to red blood cells. So next is the ratio is key to improving the test sensitivity. So this means that for detecting weaker antibodies, a higher serum to cell ratio can make all the difference. For instance, well, the minimum effective ratio is 40 is to 1, which could be achieved with 2 drops of serum and 1 drop of 5% RBC suspension. Using a higher ratio like 133 is to 1 can significantly enhance the detection of weak antibodies. This adjustment is crucial because it allows for more accurate detection and interpretation of results, particularly in complex cases where weaker antibodies are present. Remember, guys, the goal here is to refine our testing techniques to ensure we're getting the most precise and reliable results possible. So, albumin is quite interesting because it facilitates closer contact between antibody coated red blood cells and promoting aggregation. This is crucial because it enhances the reaction sensitivity. One of the benefits of using albumin is that it significantly reduces incubation time from the typical 60 minutes seen in the saline method down to just 30 minutes. This can be a game changer in a busy laboratory setting. However, it is important to note that albumin is rarely used in routine IAT testing. Despite its advantages, other media have become more commonly adapted for routine use. As we move forward, we'll explore another reaction medium that has gained popularity in recent years. Lys is a crucial factor in enhancing antibody uptake. It works by reducing the zeta potential of red blood cells, which allows antibodies to attach more easily. This process significantly decreases the the incubation time from typical of 30 to 60 minutes down to just 10 to 15 minutes, making the testing process much more efficient. The optimal serum to cell ratio when using Liz is 2 drops of serum to 2 drops of a 3% RBC suspension, as demonstrated by Moore and Mollison. This specific ratio ensures maximum effectiveness and sensitivity in the test results. There are two forms in which Liz can be utilized: Liz suspended red blood cells and the more commonly used Liz additive reagent. Understanding and choosing the appropriate form of Liz is essential for the testing protocol. We also have PEG or polyethylene glycol. It is an important factor in AHG testing we're focusing in this slide. So PEG is a water or PEG is a water soluble polymer that assists in increasing antibody uptake. It operates based on the water of hydration theory. Essentially, PEG works by removing water molecules, which in turn concentrates antibodies. This process enhances the detection of clinically significant antibodies while reducing the interference from insignificant ones. One key advantage of using PAG over the reaction media, like Liz, is its effectiveness in detecting these significant antibodies, making it a valuable tool in certain testing scenarios. So let's move on to discuss how temperature and incubation time can further influence AHG testing. So for the temperature, most IgG antibodies react optimally at 37 degrees Celsius. This temperature is not only crucial for antibody reactions, but also ideal for complement activation, which is a key part of the immune response. Now turning into incubation time, this can vary significantly based on the medium used. In saline suspensions, the incubation time ranges from 30 to 120 minutes. However, when using LIS or PEG, this can be reduced to just 10 to 15 minutes. This shorter time frame enhances efficiency but requires careful monitoring. It's important to note that prolonged incubation with LIS can lead to antibody elution, which reduces the sensitivity of the test. This is a crucial consideration for ensuring accurate test results. Under this, Understanding these factors and their impact on HG testing is essential for accurate and efficient results. So, the washing of RBCs. So, you should know at least three saline washes are essential before adding the AHG reagent. So, this process removes any unbound serum globulins, which, if left, could neutralize the AHG and lead to false negative results. Mention the role of Jack cells. We should. Why mention it, guys? Because Jack cells are IgG coated group O cells in confirming whether the washing was adequate. So it can also tell us if the washing was properly done. And RBCs should be washed immediately after incubation to prevent the elution of low affinity antibodies. Additionally, ensure that any residual saline is discarded to avoid diluting the HG, which could compromise the test sensitivity. So let's check key points regarding factors affecting HG testing on this slide, guys, on this part. So saline for washing. So it's crucial to use fresh or buffered saline with pH between 7.2 and 7.4. Using Wyman, because using old or contaminated saline can lower the pH, so tends to become acidic, which may cause antibody elution and lead to false negative result. So on the other side, contamination could also lead to false positive. So always ensure your saline is fresh and properly buffered. So moving on to the addition of HG, it is important that it is added immediately after washing to prevent antibody elution. Make sure to use the proper volume as per the manufacturer's recommendations. If you're encountering issues, using the volume of your AHG can sometimes help, but always follow the guidelines. Finally, let's consider centrifugation. So, standard settings are usually 100,000 RCF for 20 seconds or 500 RCF for 50 to 20 seconds. However, remember, higher RCF might increase sensitivity but also cause issues like false positives due to incomplete resuspension of false negatives from overly vigorous suspension. Thank you for your attention. Please study very well and be ready for the next week's actual laboratory class. God bless and enjoy life. Thank you, guys.